Triage and neurologic complications. 2. Cardiopulmonary emergencies. 3. Renal and GI issues. And 4. We'll wrap up with the ever-critical infection and fever timelines.
Okay, Section 1. Triage and neurologic complications, establishing the baseline. Our absolute first priority in any post-op patient is securing stability and catching those neurologic deficits before they can cause permanent damage.
So, the crucial point here, the golden rule of post-op care, is that you always start with your ABCs: airway, breathing, and circulation. You've got to evaluate hemodynamic stability right away. And listen, if you see new multi-organ failure or shock that literally isn't budging with a fluid challenge, you immediately escalate them to the ICU. You just can't get tunnel vision on a single symptom if the patient's entire foundation is crashing, right?
Now, when you're looking at neurochanges, you have to rapidly differentiate what you're seeing. Is it altered sensorium, like somnolence or confusion? Because that usually points to a systemic issue. We're thinking hypoxemia, shock, or maybe narcotics, which, hey, might just need a quick push of naloxone. On the flip side, focal deficits, things like sudden unilateral weakness or slurred speech, those absolutely scream acute stroke and demand an emergent head CT. Seriously, do not mix these two up.
What if your patient drops into status epilepticus, meaning a seizure lasting more than 5 minutes? You literally need to have this exact step-up management algorithm memorized. First up, secure the airway and establish IV access. Next, push IV lorazepam right away. That's your 2 to 4 milligrams. Concurrently, you're loading them with parenteral phosphonidone. And if they are still seizing after that, you move straight to your second line, a phenobarbital loading dose at 20 milligrams per kilogram. Lock this one in.
Moving right along to Section 2, cardiopulmonary postoperative emergencies, the silent killers. Let's head to the chest and see how surgical stress turns into life-threatening cardiovascular and pulmonary events. Check out the timeline on this one. Notice how incredibly sneaky post-op myocardial infarctions can be. They frequently lack classic chest pain on days 0 and 1. Instead, they present silently or maybe with super atypical symptoms like dyspnea or abdominal pain. But look at the peak incidence. Post-op day 2 is the classic timing. Basically, any new chest pain or unexplained tachycardia on day 2 means you need an immediate cardiac workup. And if that EKG shows ischemia or the troponins are bumped, boom, you initiate this rapid treatment protocol without any delay. Get an emergent cardiology consult on board and get them on telemetry monitoring. Throw on some oxygen to keep those sats above 90%. Give them 325 milligrams of non-enteric-coated aspirin. For the pain, you're doing sublingual nitroglycerin every 5 minutes, assuming they aren't hypotensive, of course. And finally, if they're hemodynamically stable without heart block, hit them with IV metoprolol to decrease that sympathetic drive.
Shifting gears to the lungs and acute dyspnea. You have got to be able to quickly contrast atelectasis against a pneumothorax. Atelectasis is basically ubiquitous in those first 36 hours post-op. Those collapsed alveoli are usually easily treated with some aggressive incentive spirometry and deep breathing. But if you're suspecting a pneumothorax, especially a tension pneumothorax, that needs an urgent tube thoracostomy, or a rapid needle decompression through the second intercostal space if the patient is totally unstable. All right, Section 3. Renal and gastrointestinal issues, fluids and flow. Let's drop down into the abdomen and pelvis. Our focus here shifts entirely to fluid balance, urine output, and getting those normal bowel mechanics back.
You absolutely must know this definition cold. Oliguria is strictly defined as urine output of less than 0.5 milliliters per kilogram per hour. In the early perioperative period, your knee-jerk reflex should be hypovolemia, meaning either they're under-resuscitated or they're actively bleeding. Assuming normal cardiac function, giving them a fluid challenge of half a liter to a liter of crystalloid is basically both diagnostic and therapeutic here.
Okay, this lab evaluation table, it is literally high-yield gold. Memorize this to instantly tell prerenal azotemia apart from intrinsic acute tubular necrosis, or ATN. Look at the FNA, the fractional excretion of sodium. It's less than 1 in prerenal states because the kidneys are just frantically holding on to sodium in water that gives you a highly concentrated urine osmolality, greater than 500. But with intrinsic ATN, those damaged tubules can't reabsorb sodium, so FNA spikes above 1 and the urine osmolality drops below 350.
Building on that, let's look at the strict definition of acute kidney injury, or AKI. It's defined as a serum creatinine bump of 0.3 milligrams per deciliter, or a 1.5-fold increase above the patient's baseline, all in the setting of oliguria. When you see these numbers, red flags need to go up everywhere. And whatever you do, strictly avoid radiologic studies using IV contrast. It will absolutely exacerbate the renal injury.
Moving over to the GI tract. Get this. Up to 20% of patients who undergo extensive abdominal procedures suffer a paralytic ileus. If they show up with obstipation, nausea, and distension, but your plain films show air in the colon, which rules out a mechanical obstruction, you follow these exact steps. Make them NPO, strictly nothing by mouth. Start IV fluids. And strongly consider placing a decompressive NG tube. Because this is non-mechanical, patience is really your ultimate treatment here. Just watch the clock. If that ileus hangs around for more than 7 days, you'll want to consult nutrition for TPN.
Okay, final stretch. Section 4, Managing Postoperative Infections, Timelines, and Targets. Let's pull all these concepts together with arguably the highest yield topic you'll face on exams and morning rounds. This timeline right here is your ultimate diagnostic map. If a fever spikes while they're still on the table, intraoperatively, you're thinking malignant hyperthermia or a transfusion reaction. Fevers in that first 24 hours? Classically atelectasis, though a super high fever could be a devastating strep or clostridial wound infection. But fevers popping up beyond 72 hours? That should immediately trigger a hunt for the classics: UTIs, surgical site infections, pneumonia, DVTs, or infectious colitis.
Now, to actually prevent these infections, the Surgical Care Improvement Project, or SIP, mandates these high-yield core measures. It specifically says you need to get prophylactic antibiotics in exactly within 1 hour prior to incision. And you've got to discontinue them within 24 hours post-surgery to prevent C. diff, unless it's cardiac surgery, where you get 48 hours. A couple other huge things. Use clippers for hair removal, absolutely no razors. Pull that Foley catheter by post-op day 1 or 2, and tightly manage perioperative temperature to avoid hypothermia.
This table brilliantly illustrates how the preoperative field classifies wound infection risk. See at the top? A clean, elective case with no GI, GU, or respiratory entry carries a mere 2% infection rate. But look down at the bottom. A dirty wound, like a traumatic, perforated viscus or frank pus in the operative field, that skyrockets the infection risk all the way up to 70%, completely altering your antibiotic management and closure strategy.
Okay, what if your post-op patient develops C. diff after getting antibiotics? First, you need a positive stool toxin assay combined with clinical diarrhea or an ileus. For severe cases, you aggressively treat based on their oral tolerance. If they can tolerate it PO, by mouth, you hit them with oral metronidazole and oral vancomycin. If they're NPO, you pivot. You use IV metronidazole along with per-tube vancomycin. And don't forget this classic exam trap, you treat their first recurrence exactly the same way as the initial episode.
All right, I'm going to leave you with this classic, complex post-op scenario to test what we just covered. A patient on post-op day 3 develops a fever of 39 degrees Celsius, oliguria, and sudden unilateral weakness. Based on our rapid review, what are your immediate next steps to triage and treat this patient? Think about those focal neurog deficits, the fluid status, and that 72-hour fever window. Master these connections and you'll absolutely master the wards. Keep reviewing and stay sharp.